Good morning, good afternoon, and welcome everyone to this observatory webinar. Today, we're going to be talking about a recently published policy brief dealing with the challenges in urgent and emergency care. What are the policy options? Now, the provision of high quality and responsive urgent and emergency care is a key capability of healthcare systems. Urgent care is care provided for illnesses and injuries that require prompt attention, but are typically not sufficiently serious to require more specialist emergency care services, whereas emergency care is time critical and much more serious. Now, both are very visible to the public, and their performance is critical to delivering high quality outcomes, as well as maintaining public support and confidence in healthcare systems. So emergency and urgent care covers a continuum of services, from the community to health centres, to primary care clinics, to hospitals. And differences in history, geography and resources means that there is no standard model for an emergency care system in Europe. The systems can be complex and not always easy for patients, the public, or even health professionals to understand. However, many health systems in Europe are experiencing high and growing demand for emergency care. This is often leading to overcrowding and long waiting times for treatment. This is also having a negative impact on staff morale and retention. So in this webinar, we will give you a rundown of the key findings from our new policy brief on urgent emergency care, which is available free to download from our website. My colleague Astrid will post a link in the chat box for you all. We will then shine a spotlight on reform programmes in Denmark and Portugal to explore some of the potential policy options for dealing with the challenges we are all facing in emergency and urgent care. Now, as ever, with our webinar series, we have an awesome panel of speakers today to explore this topic. First up, we have Nigel Edwards, Honorary Professor at the University of Birmingham and Senior Expert Advisor at the European Observatory on Health Systems and Policies. He's an independent health policy expert working as an advisor with WHO and a number of UK organisations on health policy, planning and change management. He was also Chief Executive at the National Trust from 2013 to 2023, and indeed the lead author on our emergency care policy brief. We then have our excellent spotlight speakers who will be taking a closer look at some specific country examples. We have Professor Carsten Wrangbæk from Copenhagen University in Denmark, who's also a valued member of our Health Systems and Policy Monitor Network. And he'll be telling us all about the reorganisation of emergency care in Denmark. Next up, we'll have Alexandra Lorenzo, who is currently at Nova School of Public Health in Lisbon, Portugal. And Alexandra will tell us all about the exciting results they have had in a regional pilot that is improving access to primary care to reduce pressure on emergency services. Then last but not least, we have our wonderful colleagues from the Health Workforce and Services Unit at the WHO Regional Office for Europe, Thomas Zapata and Mafaten Chawali, who will put all of this into the bigger picture. After this, as ever, we will then have plenty of time for your comments and questions from the chat box. So please don't be shy, ask your questions, and we welcome your comments, insights, and country experiences too. The chat box today will be moderated by my wonderful colleague Astrid Eriksson in Berlin. So, without further ado, I would like to hand the floor to Nigel, who's going to give us an overview of the policy brief. Thank you very much.
Thank you, Erica. I'm going to pick out some of the challenges in the urgent and emergency care system because there was a lot going on, and these are highly complex systems with many different dimensions to them and quite a lot of problems associated with all of them. So the first thing I think that comes out looking across the system is the need to really rebalance the system towards primary care. Quite a lot of patients bypass primary care for conditions that could be quite easily managed in primary care, and quite a lot of the reason for that is it's just not available, or it's not available for certain parts of the week. So the sorts of policy actions that we see people taking in response to that are methods to strengthen primary care's capacity, its ability to do diagnostics, for example, its responsiveness is open for extended hours, and creating organizational models, so networks, local hubs to be, for example, so where patients can go to keep them away from the emergency room, because once you're in the emergency room, there is a severe risk that you will be sucked into the hospital system. To be able to do this effectively, these primary care systems do need diagnostics and indeed digital tools, sometimes to get advice and guidance from the hospital, but also to be able to actually resolve cases without onward referral. If that's going to work, you've got to have mechanisms to get patients to the right levels of care. Some of the co-payment systems that we've got contain perverse financial incentives. On the other side, some of the models that are available that operate, for example, in the Netherlands, do provide a degree of financial incentive to use a better, more cost-effective, rather, model of care. So there is work to do in a number of systems to ensure that the co-payments and reimbursement models actually support the service use that we want to see, and indeed where we've got these financial incentives in place, that they aren't making things worse in terms of inequalities or unmet need. Probably more effectively is just creating a sort of architecture of choice in which patients naturally seek the most cost-effective and indeed convenient model of care. And an important part of that is providing really good, high-quality telephone triage. Quite a lot of the systems that simply rely on algorithms tend to be a bit risk averse. It does appear that the more senior clinical opinion you can get in your triage system, the better. But I think as AI develops, we're going to see some interesting innovation in this space where we can make sure that we get patients to the right place first time. If this doesn't work, patients will ignore the advice they're given or try and bypass it. In some countries, there is a model in which you are required to phone first before you go to the emergency room, and that seems to work. That does seem to work quite well, but it does really rely again on there being high quality primary care options that you can send patients to. That might be one of these primary care centres that we've talked about. It might be pharmacies with extended hours and prescribing abilities, or it might be a range of other community-based provision. But you have to have alternatives if you're going to triage people. And one innovation in this area that's really worked well is empowering ambulance services to make more decisions about whether to take people to hospital. Those countries that have used doctors on their ambulances may be better at that, but we're certainly seeing a sort of convergence across Europe as perhaps there are fewer doctors and more paramedics. But the key thing here is having people with sufficient clinical skills to make that decision, and the support in terms of making that decision by getting telemedicine advice or other support, either from the hospital or from, in a case, a friend of mine sitting at home as a consultant physician giving advice to ambulance services over the phone. So if that's going to work, patients need to trust us, and patients' decisions are really influenced by how urgent they think it is and whether or not they think they will get a good response. So it's also about convenience, their health literacy. It's not just about clinical need, and there's more to do to use behavioural insights to improve the design of some of these triage systems, to build trust in primary care and its capability and availability, to develop the triage systems and to make sure that the public have really got confidence in those. One model we see in some countries is having those systems being able to book people in to their general practitioner, to family doctor, to the emergency department, or to an urgent treatment centre or a local hub, which gives patients the confidence that they will be seen. It means patients don't spend long periods of time waiting, and it will get away from the risk that patients shop around seeking second opinions or making use of different services that aren't so appropriate for them. But we haven't done enough enough in this area. I think there's more to do to understand how patients think. And to some extent, this is about adapting to the way that patients think rather than thinking we can get the patients to do the things that we want them to do. To some extent, we have to be able to respond. Another big insight is these are very complex systems, and the parts are interconnected. So one important thing is having some mechanism to be able to do regional coordination and some form of governance, so that you can standardize the triage pathways and the system entry points. That you've got a framework for creating shared patient records, so that in the emergency department you can look at the patient's history, you can make decisions, more informed decisions about whether or not how ill is this patient compared with their baseline, for example. The development of hospital emergency departments with specialised emergency medicine staff we're seeing in many countries. This is increasingly the norm. You'll hear later about primary care urgent treatment services, but again, very important to have these extended hours. But being a bit aware of the risk that if you create this and you don't have a good triage system, there is a risk of supply-induced demand, and people will attend this for things which, to be honest, they were self-limiting, or they could have treated it themselves, or they could have gone to a pharmacy or a lower level of care. So care is required to understand that. Many hospital emergency departments are full of patients waiting for beds. So part of a really effective emergency care system is also ensuring that you avoid the problem that is sometimes called exit block. Can you get the patient out of the emergency department into a bed? And in a lot of places, we're seeing that being a problem. So the ability to mobilise step down home care, hospital at home, much improved discharge services are really important. Another bit of this system, which is becoming increasingly difficult as we're reducing the number of acute beds in many countries in Europe, is ensuring that you've got sufficient hospital capacity to be able to deal with demand surges, and that may the ability to even open beds at short notice. Hard to organise. Always the risk that once you've opened them, they become very difficult to close because of the supply-induced demand problem. And increasingly, I think seeing the use of real-time data across whole systems, so that you understand the capacity in the urgent care system, in the urgent care centres, in the emergency department, in the hospital, and in the out-of-hospital care for step down and step up, like hospital at home and virtual wards. So maybe even the development of sort of control centre type models, which we're starting to see in bits of the UK, for example. The demand is going to continue to rise because of aging and multimorbidity. This audience will definitely understand that. So we need to be supporting urgent care systems to be able to adapt to patients with multiple chronic conditions. So one part of that is trying to do more in primary care to target people who are at risk of admission to hospital, and this is about developing population health management approaches in primary care and giving better support to patients with long-term conditions. A particularly successful intervention is targeted support and remote monitoring for nursing homes, so that staff in nursing homes can respond to a crisis. The patients have an advanced care plan, so they don't necessarily need to go to hospital if they, for example, get pneumonia, and maybe don't spend the last hours of their life sitting on a trolley in a brightly lit corridor, which is not what we would wish for anyone. So some big implications here in terms of the workforce, because increasingly our workforce is probably misaligned with some of this emergency demand, and particularly the growth of specialisation. The doctors are becoming more specialised. The patients are becoming more general. So we really have insufficient numbers of people who have generalist, particularly physician skills, and urgent care skills. So there's more to do there. There's a lot more that paramedics, pharmacists, nurse practitioners, and allied health professionals can be doing to support the system. Much of the low end of urgent demand can be dealt with by people who are not doctors. if they have appropriate support training, access to a doctor when they need advice, a shared care record when they can where they consult about the history of the patient. But the capability, particularly of paramedics, to take decisions about taking people to hospital, to provide immediate treatment, and to also be a point at which you mobilise other home care support to stop the need to take people to hospital is increasingly important. But we've got more to do to attract people into these roles. They're high pressure, they have a high cognitive load, and they're particularly difficult to recruit to in rural areas. And I haven't really got very good answers for that. And increasingly, we're having to rely on transport rather than recruiting staff providing services locally. The important takeaway, I think, really is to realise that quite a lot of when we talk about pressure on emergency departments, much of this is actually a feature of the rest of the system. If your emergency department is full of people with primary care conditions, that's a problem with primary care, not with the emergency department. And if you just try and solve that problem in the emergency department, you may just attract more demand. You won't solve the problem. Many of the solutions we adopt, because they are planned atomistically, simply move the problem somewhere else in the system, which means that reform requires much more coordinated action across primary care, ambulance services, the design of workforce, the digital platforms that patients can use to deal with the system, the discharge system, and the hospital at home care system that allows us to treat more people in their own homes with IV antibiotics or fluids or other forms of support which we used to use for the hospital. But you need to think about this in a system way. You cannot optimize the emergency system by just optimizing one component of it. Thank you. Erica, back to you.
Thank you so much, Nigel. I think the main key takeaway I'm going to take from that is that complex systems require complex solutions. And so now we're going to look at some of the solutions that different countries have come up with in our country case studies. And first of all, I'd like to hop over to Denmark, Copenhagen, where Carsten Vrangbæk is going to talk about the experience there. So Carsten, over to you. Thank you.
Thank you, Erica, and thanks, Nigel, also for a very interesting introduction. A number of the same issues and dilemmas are being discussed in a Danish setting, and we have also worked on some of the suggested solutions from Nigel. It's not perfect; it's work in progress. But let me share a bit of the experiences from the Danish case, and then we can discuss afterwards what worked and what didn't work. So let me just find my slides here and start the presentation. So in Denmark, we have introduced a phone-based triage system, which is kind of the first line that you should approach if you, as a patient or a citizen, have a need for acute or emergency care services. Basically, it works in the way that there are 3 entry points. So you have during office hours. The idea is you should call your own GP. So it's primary care that has the main responsibility during office hours to deal with the majority of these acute care needs. After regular hours, we have actually different systems in the different regions, but mostly it works by calling a central phone number for regional services or for a GP organized network of emergency services. And what they do then is to triage either to next day services by their own GP or to home visits or refer on to emergency clinics, which are often co-located with the hospital emergency clinics. So it's kind of a two-way street there. If you have a serious acute emergency, then you would call a national emergency telephone service number, which also deals with fire and crime issues, etc. And they will triage based on algorithms and also individual assessments. They will activate, or they may activate, pre-hospital services, which would be ambulances or in some cases helicopters. And as Nigel mentioned, there's been an effort to ramp up the capacity of the pre-hospital services in the sense that we have more highly educated paramedics. We have ambulances staffed with physicians, and we have telemedicine linkages from the ambulances and the pre-hospital care, so that you can actually start treatment early on, and you can communicate with the hospitals in order to decide where to go. If a decision is made that you should go to the emergency room, then you'd be taken there, and then there would be a subsequent triage within the emergency room to decide the urgency and whether or not you should be placed on a waiting list, or how the condition should be addressed. So in that sense, I've already sort of alluded to that emergency services are really part of a larger system with both primary care services, community-based services, and pre-hospital care services. And the current structure is the consequence of reforms that have been put in place in Denmark, particularly since 2007, where there was a major structural hospital reform in Denmark, centralizing to fewer regions in charge of hospitals, and then centralizing the hospital services within the regions. It was part of the plan here to establish what we call joint emergency receptions, which is really an attempt to try to centralize and upscale the emergency capacity within these 21 hospitals. That was followed by investments, also investments in training and the establishment of a specialist doctor education in emergency medicine. The idea here is that when you enter the joint emergency receptions, you would meet the emergency specialist doctor, and he or she would have access also to various diagnostic services, and also quite easy access to specialists from the individual specialties within the hospital. So in that way, where you have highly specialized services up front, meeting people or patients when they enter the emergency room. Then another part of the scheme was to develop municipal care, so municipal, local, home-based care and institutionalized care. And all of the municipalities have been working with acute teams. And the idea here is to be able to go to patients or to deal with patients on a short-term basis, and try to do triage and assess whether or not it's necessary to refer on within the emergency care system. So these are both acute teams for home care and acute beds, which are places where you can stay temporarily, for instance, before being admitted to hospitals, so you can kind of assess whether or not it's necessary, or you can be admitted in order to stabilize after discharge from hospital. And that's addressing one of the other points that Nigel mentioned, that it's important to have an outlet that everybody is comfortable with after being discharged from hospital. All of this is supported by national guidelines about acute receptions, and in principle, this should secure kind of a standardized and uniform way of doing things. But in reality, there is diversity if you look across the 21 emergency rooms. So things are not sort of fully standardized or perfect. There's room to adjust for local conditions, and sometimes there may be recording issues or recruiting issues as well. Then just the final 2 points. The Danish health authorities, of course, follow this closely, and they develop guidelines and recommendations, for instance, in 2020. And then the final point is that because this doesn't work perfectly, and because there are other issues to fix in the Danish healthcare system, a new reform has been decided, which will further integrate municipal and regional acute functions, and also integrate psychiatric or mental health and somatic care at the regional level. I'll stop here then. Thanks.
Thank you so much. Thank you so much, Carsten. I think, yes, there are many things to be learned from the Danish experience. One of them being that, yes, indeed, complex problems need complex solutions, and those solutions need to be monitored and adjusted accordingly. It's not a one and done thing. So moving rapidly on to Portugal, moving from north to south. Alexandra Lorenzo, please do tell us all about what's been going on in your region. Thank you.
Oh, thank you, Erika. Now, mostly the what I want to present is really the experience that we had in the last years in Portugal. So mostly we need to realize that we are one of the countries from OECD that has the highest number of emergency room episodes per capita. And I was one of the persons that was believing that people were ignorant to go to the emergency room 10 years ago, 15 years ago. And actually, the issue is that mostly in our case, people don't thought, or the citizens don't have any choice of solutions outside the emergency room. So what we started to go, and I will only present measures or upstream measures, because we also implemented some downstream measures after the emergency room. But the upstream measures were a comprehensive approach that started mostly when developing a specific phone triage system that currently is mostly developed and operational in most of the country. It's a voluntary phone triage system, and mostly the advantage that it's separate from the 112 system, so the urgency call system. And actually, mostly the advantage that any citizen has to contact that number is really to have routing the patients to the right level of care, mostly on booking an appointment or their GP or other services, also to promote self-care or to send the patient to the emergency room. But we tried also to expand this service, and I will show you a little bit what are the results and what we have mostly developed in the Coimbra local health units, where we bring together 8 hospitals and 69 primary care centers. It's a huge organization currently with more than 10,000 employees that provides care for a specific catchment area. So let me just show you some of the data. So if you can follow me, and in this diagram, what we're going to see is really the number of emergency rooms episodes per week, starting on the 1st October to the 3rd of September. And also what I want to show is that our emergency rooms, they have something like 600 to 700 episodes per day. So it's a very demanded service. And this you can see this year in 2022, 2023. So after COVID, actually we have seen also an increase of the demand of the emergency rooms. And then this from 2023, 2024, you always see this seasonal effects. But again, we started the program mostly on the 4th of November 2024, initiating the phone triage system and then implementing other measures. So one of the measures was really to have more flexible hours on the GPs, on the primary healthcare teams, mostly according to the incidence of respiratory infections. So we monitor on a weekly basis what was the incidence of respiratory infections, and actually we activated different levels of services. So different levels were related with this incidence, but they would open all family units until 8 p.m., the other level until 10 p.m., and another level Saturdays, mornings and afternoons, and actually the last level also being open on Sundays. So if we contact directly, you can go directly to your GP, but if you call the phone triage system, we would go on a specific time slot to your family doctor. What we notice is that even though this was a good solution, we wanted mostly to increase the level of resolution in proximity. So we also developed what we call acute care centers in proximity and close to the population. And these acute care systems, mostly what with these care centers, mostly what they provide is also, it's a family doctor that is there with a nurse, but also we provide blood analysis, ECG, and X-rays. So what we noticed clearly was a reduction in more than 20% of the episodes per week. So this kind of implementation showed us that we can manage demand to the emergency room, and actually it had a huge impact also on the quality of services provided to the emergency room. We reduce, and as an example, the time from triage to the first medical observation from 70 minutes to 50 minutes, and it was a huge gain. So Erica, that's it.
That's wonderful. Thank you so much. I think we're going to get a lot of questions in the chat box, especially about telephone triage. I think that seems to be one of the things that goes across both case studies. So now we're going to go to the macro level. We're going to jump across and welcome Thomas Zapata, who's going to talk from a WHO Europe perspective. Thank you very much.
Thank you so much, Erica, and really a pleasure to co-develop this policy brief jointly WHO Europe and the Observatory. 3 main points from my side. The first one, I think emergency services are often the pressure valve of wider health system challenges. So when other parts of the system are really struggling, are really overstretched, overburdened with high workload, patients end up in emergency departments in hospitals. And I think this is something that is telling us about the importance of taking a more comprehensive approach, because at the end of the day, what we see is that patients are seen far from their places in many cases, and at the same time, they are not taking the right care in a sense that could be taken in other part of the system. Second point is that as a reaction of these overcrowding emergency departments, the tendency in some countries and some circumstances is to further increase the capacity of emergency rooms in hospitals instead of taking a wider approach. So, and health workforce is another element in this one. So what we see in some countries is that the doctors and nurses working in emergency departments tend to increase over time, while primary healthcare workforce remain flat or even diminishing numbers. So at the end of the day, what is this doing is perpetuating the problem and not addressing the root causes and having a system-wide approach, as I was saying before. And that takes me to the third point, which is basically the importance, as Nigel was saying, that is a complex problem that requires complex solutions and a wider systems approach. And here I think is reinforcing the message that it's really important to invest from a financial perspective, but also from a health workforce perspective in primary care, so that patients are able to access care in the right place at the right time and adding value to the problems that they have. So I think the message here is basically about really reinforcing primary care so that we are able to address the root causes of overcrowded emergency rooms. And maybe later on I can give one concrete example with some figures. Thank you, Erica.
Thank you so much, Thomas. Thank you so much. Okay, so music to my ears. We're talking about investment, not costs. So this is music to my ears. But Mapaten Shawali, I'm coming over to you so we can put the patient back into the equation. So I'll hand over to you to finish off.
Thank you, Erica. And so building on what Thomas just shared, I want to shift now the focus to the people actually using these services. Well, if we look at the patient journey today, I think it is incredibly complex. And when someone feels unwell, they face multiple options. We have the telephone helplines, pharmacies, urgent care centers, we have their family doctors, or the hospital emergency departments. And as we highlighted in our policy brief, this evolution of different models has created a system that is difficult to navigate and often poorly understood by the public. We cannot just simply blame patients for making the wrong choices when when the system itself is confusing. And I think that patient bypass primary care and go straight to the emergency department, not only for clinical needs, but also this is driven by patient confidence and by patient perspectives. When people perceive that primary care is actually unavailable, especially out of hours, or if they lack the confidence in the quality of care they will receive there, they default to the hospital. We also see the impact of poor health literacy. So people attend emergency departments for concerns that could easily be dealt with by a family doctor. And they are simply less familiar with how to access services. And to address this, we need to make healthcare systems easier to navigate. And this requires, of course, drawing on behavioral insights to design services that actually make sense to the public. So we need to provide better, clearer information about how the system works. And this means standardizing our approach to entry so that patients are reliably routed to the most appropriate care. And ultimately, this comes down to trust. If we want to sustainably reduce the pressure on emergency departments, we must actively work to improve public trust in the whole system and particularly in primary care. We must empower people as true partners in their care, ensuring they have the health literacy to make informed decisions and the confidence that when they need help, the right care will be there for them. And finally, we must recognize also that patients and the public are not passive recipients of care, but active partners in the healthcare system. And so building public trust and improving health literacy so people can navigate the system effectively and managing public expectations are central to shaping demand and ensuring appropriate utilization of services. And the WHO has actually a vital role to play in championing this shift, placing the patient and the community at the center of policy design and moving towards a model of co-creating health systems that are not only efficient, but also deeply trusted by the people they serve.
Thank you so much. I think it was so important for us to come back to putting the patient back into the system at the end to sort of bring it all together. So now if I could ask all our panelists to put their cameras on, we're going to invite Astrid to come out of the chat box, which is where I spend most of my time lurking. So, and it's been a very busy and active chat box. Astrid, please do tell us what's been going on down there.
Thank you, Erica. Yes, it's indeed a very lively chat box, which is great to see and follow along with. I've tried to sort of group a couple of questions under the same headline. And as you mentioned earlier, Erica, it seems like there's a real interest in learning or hearing more from the panelists about national telephone and online triage services. So we had questions around patients bypassing lower levels of care, overcrowding, and patient accessing services at the right entry level. And I know that the policy brief and also the presentations today have already touched upon it. So I would like to invite the panelists to expand on these triage services, perhaps talk a bit more about their benefits, their challenges, and the ways forward. Thank you.
Thank you. So, Nigel, I'm going to hand over to you first. Triage, telephone triage. How does it work? What are the pitfalls? What do we need to look out for?
Yeah. So quite a lot of telephone triage systems are using algorithms of varying levels of quality. That by their nature, they have a tendency to be risk averse. So if you just rely on the algorithm, you tend to send more patients to the next level of care up from the one that the patient may actually need. So a number of countries combine algorithms with clinical insight. So the algorithm can help you deal with the how to route patients who need relatively minor conditions, particularly in situations where there's a very complex web of services. The algorithm can help you locate what is the most appropriate place to go. But I think there is the gold standard probably is to at some point speak to someone reasonably experienced, quite senior and experienced, reasonably close to the beginning of the process, rather than being just dealt with algorithmically. So you use the algorithm to identify people who are absolutely obviously can be sent to relatively low levels of care, and then you have increasing levels of clinical involvement in the triage decision as the cases become either have higher levels of uncertainty or certain red flags that signal that you should have a preferably a doctor, but actually nurses are also very effective in this area.
Thank you very much. So
triage, I should say triage is probably the wrong word, right?
okay.
I mean, what we're actually doing is sorting out patients into the right flow, whereas triage tends to be used for it's battlefield assessment of urgency. So it's probably it sets up the wrong idea in quite a lot of people's mind about what it is we're actually trying to do. We're trying to find the most appropriate level of care rather than necessarily identify urgency.
Okay, so it's about finding the right route, finding the right path for that particular patient. So Alexandra, you showed us a beautiful graph. Was this kind of thing a big part of that?
No, it is. The phone triage system plays an important role, but it's not the only solution and shouldn't be the only solution or the silver bullet for the system. In our case, it's a voluntary system, but across the country, we had a reduction in 8% of the emergency rooms only with the phone triage system, but we got a little bit further with these extended hours in PHC related, actually with the infectious respiratory diseases, but also we increase the time slots and we monitor the time slots for acute care in primary care. I need also to, and also of course, the acute care centers that work out of hours of primary care that also have this ability to answer patients when they need, and in some cases, of course, usually family doctors, they are not available at that time. But I need also, related only to the phone triage, I believe that we need also to add something, because the phone triage systems, of course, they are a general solution. But what we notice is that, for example, with population of specific and complex needs, like elderly people living in or institutionalized in elderly homes, we need different solutions. So what we introduced as a pilot was really our home hospitalization, hospital at home department. They started to give clinical or training to the technicians that work on those facilities, but also to train them, also to call them. And we created a phone line, a direct phone line to those services, to the nurses and to the doctors, to give support for acute care on the elderly home, with the possibility of activating our services also to go to the elderly home. I think that kind of segmentation of the population needs to be done for us to really manage the demand of urgency services. If not, this general phone line triage system, of course, is directly for the overall population, the general population, but we have specific populations that have different needs. And the other thing is really at the emergency room, we're creating other ways of entering the system. So mostly with day hospitals that could also receive acute patients in mental health, diabetes, cancer, mostly to redirect patients from the emergency room to other services that are there open. So we need really to develop different services and different approaches according to each reality, but mostly to avoid and to reduce the number of patients that go to the emergency room.
Okay, so yeah, again, it's very much about sifting and sorting the patients and making sure they're going in the right direction to get the most appropriate care for their needs.
Yep.
So, Karsten, Thomas, Mafaten, does anybody else want to jump in on this?
Yeah. So
Yes.
So the traditional Danish system was that it was led by a network of GPs, but then the Copenhagen region decided a few years back to change that into a region-led phone triage service, and that meant patients were calling in and talking to a nurse, which would be supported by algorithms and physicians in the background, and that actually created a lot of sort of unease in the beginning, also because waiting times were a bit long, and that just highlights that it's really important that you get things right when you change these things. It's quite sensitive to maintain good behavior among patients, not to to spur sort of the incentives to bypass the regular routes, etc. So these are sensitive issues when you consider the behavioral issues that were also discussed previously. So behavior is at the core of this. Trust is also really important, that you maintain trust in the systems, and also that it's convenient, so that you actually have access within a time period that is what you expect. So many things can be done, and many things can be done to improve this, but you need to be careful, and you need to work with the kind of the culture and the patient issues at the same time, and you need to make sure that the services are up to par.
Yeah. So this comes back to what Mafaten was saying about sort of the system develops in response to the way in which patients use it. It's in the policy brief, I think we even call it a complex adaptive system.
Yeah.
So does anybody want to talk about overcrowding?
Oh.
Nigel and Thomas.
Yeah. Yeah, so overcrowding is associated with high levels of mortality and morbidity. Patients are more likely to die in an overcrowded emergency department. They're also more likely to die if they wait longer. The mechanism for this isn't very well understood, but it's probably because the staff are busy trying to care for patients who are stuck in the department and should have moved, and also caring for new patients who are coming in. So it's generally to be avoided. The major reason for overcrowding is not just about demand. It's what I said earlier. It's about the ability to move patients into the ward. So this is why good emergency systems really also need to focus on discharge and decision quality in the hospital. So very frequent ward rounds, making a decision and avoiding the phenomenon of what the British Medical Journal calls what if medicine, which is we'll just do one more blood screen, we'll just do one more test. You need to see, and the implication of that is we need senior decision makers present for a lot of the day. A lot of departments have tended to rely on junior people who often increasingly are reluctant to make some of these decisions. So if you have very experienced senior generalist physicians with access to good specialist advice, we have good home care and social care to be able to take patients home who don't need admitting and to discharge patients who are stuck on the ward. We can start to see flow through the system, and the creation of flow is probably the goal for making the life of the people in the emergency department bearable and ensuring that the patients get really high quality care.
Thank you, Thomas.
Thank you, Erika. No, just on overcrowding, I think one of the key issues is where do we see patients? If we are seeing patients in the right place, because sometimes because we are not seeing patients in the right place, that's why we have an overcrowded ER room. And I would like to pick just some figures here that I mentioned before. In Spain, for example, is the second country with the largest number of ER visits in the OECD, just after Portugal, and Alexander mentioned it before, 59 per 100. If you compare with the Netherlands has 10 per 100. It's much lower, the ER visits. But I think there's a key indicator here, and is that we look at which proportion of those visits in the ER departments are admitted into the ward in the hospital. And when we look at that, in Spain it's only 8%, in Portugal 5%, in the Netherlands is 35%. So that means that the Netherlands, because of the financial incentives and other measures that Nigel was mentioning before, is managing to see the patients before in the right place and is not overcrowding ER departments. So I think that's why I was referring before how we address that. And just another figure that I would like to bring is that, as I was saying before, the reaction sometimes is to increase the capacity of emergency rooms. If we look at Spain in the last 10 years, the number of doctors working in emergency departments have increased 30%, 30. If you look at primary healthcare, it's been 5% increase. So is that we are not investing the financial and human resources where they bring more added value. So I think we need to have this system perspective to look at overcrowding. Thank you.
Thank you. Alexandra.
No, I totally agree with Thomas and Nigel. I wanted also to add an issue related with human resources in emergency rooms. I believe that the lack of attractiveness of emergency rooms is huge. Usually, when they are overcrowded, it's a completely war zone, and it creates challenges related really with the health or even the welfare of the professions. I believe that what we are demanding from front line professionals, it's huge. To work in emergency room currently, it's highly demanded. It's not only to work by shifts or graveyard shifts at weekends. It's really, really highly demanded. And that's why we only get senior or junior staff to go to the emergency room, because the other ones don't want to work there. And actually, it's one of the issues that we are having on the attraction and retention. Probably is one of the areas that we have the hugest problems. Thomas has done a huge work on this, and I believe that and WHO on human resources across Europe. And I really believe that one of the areas that we need to take much more attention is at the emergency room. And of course, it's to redirecting patients to other levels of care, but also downstream really to work, as Nigel was mentioning, to increase discharges, the management of inpatients, but also to have a more flexible bed system. So mostly create partnerships even with other providers for non-acute care to increase long-term care. So there are different solutions that we really need to put in place, also to protect healthcare professionals and of course to provide much better care to our patients.
Thank you. Astrid, I noticed that the chat box is still very busy and we've only got a few minutes left. So quick fire round of questions. Just chuck questions at us and we'll see who wants to answer what.
Well, so we've talked a lot about tailoring services to local context and realities, and I would like to take the panelists down at different paths and talk about tailoring services to different population groups accessing emergencies. So very open question. Do we need a specific pathway for people with mental health problems? What are the challenges? What are the benefits? What do people need to take into account when designing these pathways? Thank you.
Okay, so specific pathways for specific patient groups. Alexandra, you put your hand up.
Totally. We really need to segment the way that we are providing care. I believe that it's not only for mental health, but for other conditions. Emergency rooms provide general care mostly to stabilize the patients and to direct it to other. That's the business model of the emergency room. And most of the professionals that are there, they are not knowledgeable of specific conditions. So if we have other doors in the system, as I was mentioning, as day hospitals for mental health, day hospital for oncological patients, day hospitals that receive acute patients for diabetes, that are the specialized teams for that specific condition, it's it's an improvement of the system. The other point I think that is really also important besides this segmentation is really to develop clinical pathways for the aging population. The geriatric emergency rooms should be a concept that we should think about, mostly because patients have specific and complex needs. Most of our emergency rooms, if we see currently, they are mostly overcrowded by citizens over 70, 75, 80 years old. And we really need to find ways of providing a different care, because at the emergency room, if you visit an emergency room, you will see that they are not being taken care as they need. And most of the times they can go to the emergency room and actually be discharged worse than they entered. And that's the problem.
Thank you very much. Nigel.
Yeah, the emergency room is not a good environment for someone who's in a mental health crisis, but they may well need physical treatment as well for injuries and other things. So you do need an environment. You do need within your emergency department an environment that's appropriate. But ideally, people who don't have a physical illness or injury, but are having, say, a psychotic episode, should probably be dealt with by a crisis team, a specialist crisis team of the type that Alessandro there was referring to, and if possible, be taken straight to, if they need inpatient care, they should be taken straight to an inpatient facility specializing in mental health. They should not, as is unfortunately often the case in some hospitals in the UK, spend extended hours in a room in a hospital emergency department waiting for a bed. So in the general principle, as we're saying, for all of our emergency care, we need to get the patient to the right people with the right expertise as quickly as possible, with as few intermediate steps as is necessary. And that probably means not taking most patients with a mental health crisis anywhere near the emergency department, if at all possible.
Yeah, so
Okay,
just
Carsten.
yeah, so just to add on to that, I agree with Nigel that if you have a clear psychiatric health need, then you should go in a separate route and be dealt with by specialists within that area. Problem is that many of the people that need acute care services, they suffer from multi-morbidity. So it can be psychiatric issues with other things, or it can be elderly with multiple complex issues. And the philosophy here with the Danish joint acute wards was to establish a specialized acute care facility where you actually have senior doctors from the specialist areas available when people come in. So you can form the teams around the needs that the specific patient has, rather than just having junior doctors in the emergency room. And then you can have these more generalist, specialist educated emergency care staff also, which is also helpful in doing the triage and putting together the teams that are necessary for the individual patient.
Yes, mental health input into the emergency department can be very helpful, and particularly to ensure the rapid follow-up of, for example, patients who've come with self-poisoning to the emergency department, to ensure that they are quickly handed over to because those patients often come back if you don't do that. So getting a close tie-in between mental health services and the emergency department will be important, because as Carsten was saying, we'll have patients presenting who actually have got physical conditions and mental health conditions, but we also may need to be able to distinguish whether or not the problem is psychiatric or somatic. So someone skilled needs to be able to sort that out and then deal with, again, our principle is get the patient to the right place as quickly as possible with as few handovers as necessary.
So I think the key message from all of this is complex. It's a complex system, and complex systems need complex solutions. I think that's our take-home message for all of this. I'm afraid we're now out of time. Thank you everyone for joining. We really appreciate seeing you all here. Thank you so much for your questions and comments and sharing your experiences in the chat box. And I look forward to seeing you all in a couple of weeks' time, when we're going to be back here talking about AI and what do we need to know. You, as people who work in the health sector, what do you need to know and understand about AI and its potential and the potential pitfalls of using it in health systems? So without any further ado, thank you everyone, and we'll see you all in a couple of weeks. Take care then. Bye-bye.